I wanted to cover, a little bit about long COVID, which we've been hearing about for a while, is becoming a bit more of a topic, and also maybe touch a little bit on the J&J vaccine and the vaccines in general, just for follow up. Just want to credit, I cribbed these slides mostly from a couple of public CDC presentations, and these are the folks that put these together. Mount Sinai has a really good post-COVID unit, um, and obviously the CDC and other places are doing research. So long COVID, really, just at the outset, I want to say that every serious viral illness, including influenza and other viral illnesses, can have what we call a post-viral syndrome. So, most people recover, but some people continue to have lingering symptoms for quite a while. I mean, many people experience a post-viral cough, for instance, which, can go on for literally weeks, in the absence of any residual infection, just because of irritation. And usually we try things like inhalers and so forth. But the thing that distinguishes long COVID in part is we've never had the entire world infected at the same time, basically, with the same virus. So, if you have 100,000 people in the United States who have flu and 10% of them have symptoms after that, you may not even hear about it or notice it, but the numbers are so huge. That may be part of what we're seeing. Obviously, there's still a lot we need to learn about it. It can have a lot of overlap, right? Because people may have been in intensive care for a while, and there's something that's well known that's a post-intensive care syndrome. There are complications from a hospitalization, and other things. So we're not quite sure, what's what sometimes. So most people say, who have it, that they have sort of persistent severe fatigue, and that's one of the biggest things. It's just more fatigued than your usual, what you would expect. Now, some of that could be just recovering from the illness, but not everyone who gets it has severe illness. Headaches are also pretty prominent, and then this kind of brain fog, which people have a hard time describing, but it's just kind of not as sharp. You can't fully remember stuff as well. You're like, what am I doing right now? Kind of, we've all probably experienced that at one point or another in our lives for various reasons. Fatigue alone can certainly do that, but that's also a prominent thing. And as I mentioned, some people with mild to moderate symptoms who never had to be in the hospital do sometimes have these long COVID symptoms. So there's kind of a graph showing that, this was about 1,700 people who were hospitalized from the early pandemic in China, who had at least one symptom 6 months after the illness, and 3/4 had some symptom. Most prominent, as I said, was fatigue or weakness. Dyspnea means shortness of breath with exertion, usually. Sleep problems, anxiety, depression, hair loss, smell, palpitations, and joint pain. So, these are all things that we're seeing, and it's pretty common, at least in that study. And this points out that 1 in 5 patients who did not require supplemental oxygen during their hospitalization, so, sick enough to be in the hospital, but not even requiring oxygen. So really mild to moderate illness. But if you do these simple pulmonary function tests, a fairly significant number had a decrease in their lung function at the 6-month point. And there's something called a 6-minute walk test, where they measure your oxygen levels. There's a little fancier test. DLCO is kind of how well the oxygen moves and diffuses from your lung into the bloodstream. So these people in blue were the folks who did not require any oxygen for their COVID, And then these are people at the other extreme who may have required high flow oxygen and were a bit sicker. So, not surprisingly, those folks had more incidence of lung problems, but still, a quarter of people in the sort of mild to moderate may have had some lung function issues at 6 months. And that doesn't mean it's permanent, but, it's just 6 months out. So this again highlights that in patients who have mild disease who didn't require hospitalization, this is a couple of studies in France, the Faroe Islands, and Switzerland, and they showed that anywhere up to half of patients with mild COVID-19 had symptoms after 2 to 4 months. And interestingly, half to 3/4 reported new symptoms not present in their acute illness, or symptoms that resolved and reappeared. And it's interesting. I just spoke to a patient yesterday who had pretty, severe. I wouldn't say severe COVID, but bad enough. He didn't require hospitalization. It was about a month or so ago, and he lost his sense of taste and smell during the illness, recovered it completely, and then this week he's sort of losing his sense of taste again. So, so we're definitely seeing that things come, and perhaps symptoms that they never had in the first place. And fortunately, a very much smaller percentage reported that their symptoms were severe. This is just another, study in France, and it's sort of interesting. This bar here on the left of this line going down the middle were symptoms that they had while they were in the hospital, okay, or while they had their illness. So, big proportion of people who lost their sense of taste and smell, a smaller proportion of people later who continued to have that problem. But there are some things like sensory disturbances or palpitations. As I have another patient, a young woman who had COVID, didn't require hospitalization, who's been, having sort of a rapid heartbeat. And even though a small number had it while they were ill, a larger number have it afterwards. So there's kind of, things that may even crop up that they didn't experience when they were sick. Again, this is just, a pretty high number of people experience these various different things afterwards. So, some of the patterns that are emerging, particularly in lung disease, are persistent symptoms, but with normal testing. PFTs are pulmonary function tests that we do as a standard test, and maybe even chest X-ray and chest CTs that look completely normal, but people still are complaining of symptoms. So that's frustrating, right? You go to the doctor, does all the tests, and he tells you you're fine, and you're not fine. So it's important to recognize we need to listen to people and their symptoms and not just go based on the tests. Some people, have more serious disease, have actual, persistent lung disease, from sort of inflammation and scarring of the lung. Fortunately, that's unusual. And then other, funkier things that are a little bit more unusual. The diaphragm may not lift up a little bit, or, a fairly significant number of people, and that's important when we talk about clots with vaccines, up to 20% of people, certainly in the early pandemic, had clots. Not all had pulmonary emboli, but many had clots in their legs. So often pulmonary emboli, they'd break off and go to the lung, or clots in other more serious areas like the brain and strokes. So COVID itself and the inflammation of it can cause a lot of clots. So the neurological symptoms, like I said, it's kind of vague. It is the most common symptom. Sort of short-term memory, concentration. Maybe you're trying to find the right word for something that's kind of a simple word. Doesn't clearly correlate with how bad the illness was, or age, or other conditions. So it's really kind of random. People have good days and bad days. And the impact on people's lives is variable. Some are fine. Some, really are out on disability because they can't do their job. A lot of people have sleep issues, long after their COVID, and then, mood issues, depression, anxiety. PTSD, particularly people who spend a long time in an intensive care unit, it's pretty awful. So these are all things that can happen with any serious illness, but we're seeing with COVID. Headaches, paresthesias, which can be sort of numbness and tingling, and dysautonomia, which is a fancy name for kind of imbalance in your autonomic system, and the autonomic system controls like blood pressure and heart rate. So those palpitations, or feeling dizzy when you get up because your blood pressure drops a little bit. So these are all things that folks can have. I had one woman who just had this really hypersensitive area on her forehead, very striking and not painful, but almost like a shingles kind of thing. But we did a lot of testing and nothing really turned up. But I think it was probably from her COVID, and hopefully will go away. But some strange things that we don't see. The treatment really is mostly symptomatic and supportive. With the brain fog, they're trying different things. Things like Adderall, or modafinil, which is sort of an alertness drug. For blood pressure and palpitations, meditation, staying hydrated, putting people on salt pills. My young woman with tachycardia got her on a low dose of a beta blocker that slows the heart rate down. You need to, potentially see a neurologist, and there's other things that can treat the sort of numbness and tingling. These are things we often use in the treatment of things like HIV neuropathy, gabapentin, Lyrica, antidepressant drugs can help sometimes. And the fatigue, we have to try to treat all those associated symptoms. And, one thing they have emphasized is not to push people too fast. So, go slow. It's not the push yourself to exhaustion and really try to, build yourself back up quickly. It's, take it easy because you can have setbacks. Usual recommendations for sleep, medications if needed. And, as I said, really, mental health is something always neglected, but it's important not to, and to really listen to the patients and, hear what they're saying, because, this is all new for all of us, physicians, patients, and, I say this all the time, but doctors, when they don't know the answer to something, may tend to say, you're fine, there's nothing wrong. It's important for doctors to be able to say, I don't know the answer. I hear what you're saying. Let's try this, let's try that, let's give it some time. And not to say that it's, due to depression or anxiety, but those things should be addressed as well if they're there. And sometimes that can help your overall physical being as well, of course. We don't really have, like I said, medication to cure these things. We're hoping, like a lot of post-viral syndromes, that with time they just get better. We're not finding, permanent damage to explain a lot of these symptoms. It may just be residual from a lot of things, and we don't want to over test and put people through a lot of things that aren't necessary. And patients are getting better. So that's the important thing to remember. So the key points, newer persistent symptoms that are 4 to 6 months after the illness is over may occur even in people with very mild disease. In addition to the breathing stuff, you could have fatigue, sleep issues, depression, anxiety, these other neurological things that we talked about. It's important to know what the baseline was, and when you start evaluating, and just to sort of continue to be comprehensive as you go along to document how things are improving, hopefully. And like I said, there's a lot we don't understand, so we need to be empathic to the patients and be able to be honest and say, when we don't understand, and refer out as needed to folks. Like everything, there are people now who are really sort of specializing this in a multidisciplinary way, and we have clinics like that here as well. And I mentioned Sinai. So those can be good things as well. So that was sort of it on the long COVID. Quickly to go through some of the issues of clots, also from a CDC presentation. These two folks from the CDC put this together. I took a few slides out. Um, so this is really about clots with J&J. As all of you probably know, there have also been something very similar reported with the AstraZeneca vaccine, which is not even emergency use approved in the United States of yet, but has been widely used in the rest of the world. But as everyone knows, J&J came out, and then we had these reports of the cerebral venous sinus thrombosis, which is a specific area that's much more serious even than those clots you can get in your leg or potentially pulmonary emboli. But the unique thing about this syndrome is that people have low platelets as well. Platelets are important for clotting. So it's counterintuitive, right? Because you know, when people have low platelets, they're at risk for bleeding because they don't have enough of these cells that help us clot. But yet we're also seeing these clots. So it's clotting with low platelets, which is something that we see in medicine rarely. You know, particularly there's something, a reaction to heparin, which is a very commonly used drug in the hospital. It's a blood thinner. That's rare. But you see the same thing of clotting and risk of bleeding with low platelets. So as I said, the platelets are just colorless blood cells. They help us clot. We usually have 150,000 to 450,000. They go to areas where there's damage and they clump up and form these plugs in the blood vessel injuries. They help clot if you cut yourself. Thrombocytopenia is what we call low platelets, the medical term for it. Anything under the normal is considered thrombocytopenia, but a little bit low, like a lot of tests, even 100, 120,000, we're not that worried. Even all the way down to 10 or 20,000. It's when you get to the under 20,000 platelets where then you're really at risk of spontaneous bleeding, rather than just, worse bleeding. If you have a bleed, you can spontaneously bleed. So that's where it's sort of a danger level. What happened with the vaccine, and I really emphasize that I think the systems worked. This wasn't like, how did this happen? It really was a tribute to the reporting that's done with all of these vaccines. Any adverse events, anything that happens, even if you don't think it's from the vaccine, we report those back into this national system. And if they start to see anything that looks a little weird, so we're talking about millions and millions of doses and initially 6 cases. And yet that was enough for the experts looking at this information to say, hey, let's pause here, let's take a look, and let's really make an informed decision. So, I not always, praising how the government has handled this, and certainly the previous 4 years, the CDC got a little bit of a bad rep, but I think they're making a comeback, and this, I think, was really a triumph of that, because it's a needle in a haystack here. If you think about this, cases scattered all over. So, this is when we started vaccinating March 2nd. There were these 6 cases reported really just over the next 5 or 6 weeks, and then they paused pretty much immediately. This is your brain. These are the blood vessels, the veins, okay, so not the arteries. Very low pressure system, kind of sluggish, but important to drain stuff away. And any of these vessels can clot. And we see this even without COVID or without vaccines or without, this does happen occasionally for other reasons. But when that happens, people can become much more ill. So it's rare in general, okay, pre-COVID or as we go along, but we do see it. This cerebral venous sinus thrombosis can happen, but only at about 0.22 to 1.57 per 100,000 people, and it's less than 1% of all strokes that we see. But it is typically in younger folks, although some are over 65 years, and it's more often female to male. Um, the um, the risk factors are other things that can cause clotting, like genetic conditions, oral contraceptives. During pregnancy or postpartum, people are more prone to clots. People with cancer are more prone to clots, infections, and then other mechanical things we do, like spinal taps, can cause clots. Usually, what happens is you get a clot and it's not draining properly, so the pressure builds up in your head. You get a headache, and if it gets bad enough, you can have vomiting, swelling on eye exam, visual problems, even seizures, or worse. But usually, people seek medical attention well before that. Rare things here are a little more medically oriented. We don't have to talk about. So what happened with the J&J vaccine was, as of April 12th, we did this pause. There were 6 reports at that time. I think there are 15 total now. Folks were coming in with these clots and low platelets. So it was about 0.87 cases per million doses administered, so less than 1 case per million. Pfizer and Moderna, Pfizer had 0 out of 97 million that have been administered. Moderna had 3, but they all had normal platelet counts. Okay. Were these related? Hard to say. We know it can happen. And again, if every day across the country, a certain number of people are having a stroke, having a heart attack, getting hit by a bus, whatever it is, just because they had a vaccine within a week doesn't mean that that's what caused them to get hit by a bus, right? Or have their stroke or heart attack. But it's important when it raises above what we expect should be seen. The original cases in the J&J were that younger age. Symptoms began about 8 days after the vaccine. So pretty early on. So you get a headache, a month later, it's not likely to be related to that. All the cases were in white females. Although now that there's 15 cases, I believe there was 1 male. When they look back, who was in the trial. Only 1 was on estrogen or progesterone or birth control. There were none that were pregnant or postpartum. There were some other risk factors like obesity, hypothyroidism, hypertension, asthma. None of them had COVID-19 itself, which can cause clots, nor antibodies. Initially, some of them got heparin, which we now know is contraindicated. You should not use heparin to treat this. But typically, it would be the thing that you sort of reach for in this situation. Some of them got platelets transfusions. Some of them got intravenous immunoglobulin, which is now recommended for treatment. 1 died. 3 were still in the hospital. A couple of them very sick, and 2 were discharged home. It's recommended not to use heparin as a blood thinner, but the non-heparin blood thinners that are usually oral, along with the intravenous immunoglobulin. And this is a kind of a busy slide, but just to show that over here on the left side is what you would expect to see in the absence of vaccines or anything else that we just see happen, by chance. Kind of a range from 0.5 per 100,000 to 2 per 100,000. But these are what we saw with the vaccine, and this is 15 times higher than you would expect at the low end, and still 4 times higher than you would expect at the high end of the range. So this is what stuck out. Not that it was happening, but that it was happening at a rate that we would, that's higher than we expect to see on a day-to-day basis. So to summarize, it's rare, but it's serious. Normally, people's platelets are in the normal range, so the tip-off for folks is seeing low platelets, that it could be this syndrome as I said, the rate after the J&J vaccine was higher than you'd expect for what we call background rates that just normally happen. They were all young women, all had low platelets, no obvious risk factors. It has not been observed after the RNA vaccines. It's very similar to what's been seen at a similar rate with AstraZeneca. Both of these vaccines, unlike the RNA vaccine, which is a nanoparticle coated, fat coated delivery system for RNA, Johnson & Johnson uses, and AstraZeneca uses a common virus called adenovirus, which has been disabled to deliver DNA of the spike protein. So they're pretty similar. They're different adenoviruses, but they're both adenovirus mechanisms. So part of the reason for the pause was to alert people and to alert us as treaters, hey, don't use heparin, use IVIG and oral anticoagulants. Be on the lookout. This is what to look out for. And for the public to, sort of take that pause and just make people alert to call their doc if they're having any of these symptoms within a week or so of getting the Johnson & Johnson vaccine. It has been taken off pause. A little controversially, they did not limit the age, which is what they've done in many other countries with AstraZeneca, and said, only given in 50 or older. But this is a situation where, again, 1 in a million, it's very safe, it's very effective, it's convenient. But we need to have that conversation, particularly with young women, in a place where we have other options. I would probably say to a woman under 50, why don't you think about getting the Pfizer or the Moderna? I wouldn't say don't do it. If that person said, I just want to do 1 shot, I don't want to do 2 shots, I understand that there were these rare cases, I want to get it, I'd say fine, it's really safe, super safe. We do things in medicine all the time that have rare possibilities of complications, right? I mean, most of the medications we prescribe, can have a very rare bad event. So this isn't really, it seems worse because it's kind of scary, it's happening in the brain and it's clots and it's, but it's highly unusual, and I wouldn't hesitate to give it to a young woman, but if I had a choice, why not do the Moderna, the Pfizer?
Is there any sort of development on vaccinations for women who are trying to get pregnant, or also on pregnant women?
Just recently, they've really come out and said, I think when the vaccines first came out, it was probably safe, have a conversation. And now they've got enough data to say that they believe it's safe. So I think that absolutely, if you're trying to get pregnant, I wouldn't hesitate to go ahead and get the vaccine. And I would strongly encourage it because there are some data that, folks who are pregnant who get COVID, it can be more severe. So you really want to be protected before you get pregnant. But same reason, I think it seems to be very safe, and they'll continue to collect data on that.
Great. Yeah, I can imagine that the idea is, to keep yourself protected in that sense if you're trying or
absolutely
currently pregnant. Have there been any updates about women who are pregnant and have been vaccinated, then having babies that are born with antibodies? I should say people who are pregnant and having babies born with antibodies.
Oh, you mean in terms of like
they're born
vaccine immunity?
Yeah, vaccine immunity as opposed to
think,
having had COVID.
Yeah, I don't think we know anything about that. Usually some antibody can passively transfer over, but that said, we don't know if, even if a baby tested for that, whether it was really protective.
Gotcha. Okay.
And the baby's immune system takes a while to develop. And this, of course, is something that we ran into in the early years with HIV, where, pretty much all babies were born, quote, positive for HIV with the antibody. But it was just passive transfer, from the mom. So it wasn't until, viral load came along in the late 90s that we were able to actually test for the virus itself, which is really the definitive test. And the same
Gotcha.
is true for a lot of other antibodies that passively transfer over, which may or may not be protective, and they won't last
Hmm.
either. The baby's then going to have to generate their own over time.
How does that relate to breastfeeding too? Would that be the same sort of perhaps antibodies are passed along, but they're not necessarily protective?
Yeah, I mean, you could imagine they might offer some slight protection, but
Hmm.
remember, a lot of the protection comes um, not only from the antibodies generated by a vaccine, but the fact that in COVID, T cell immunity is really important as well. That's something we don't really measure with any kind of a test. But when you do the vaccine, you're stimulating both B cells and T cells. The B cells produce the antibodies. And most importantly, you're creating these memory cells um, that kind of are around. And the minute you're exposed again to that, those memory cells really fire up and produce more antibody or more T cell response. So it's not just the antibodies that you develop at the time of the shot, but it's also
Hmm.
that memory that your cells have. And that's what you wouldn't get really with passive antibody um, transfusion
Mm.
to a baby. They're not going to have these memory cells. They're not going to be able to produce it on their own. They just have some antibody for a while.
That's really interesting. Just the difference between the two. Is there any sort of oral COVID medicine coming out?
Nothing
Hmm.
yet. They keep looking,
Hmm.
everything sort of has a day in the sun. And then, they're like, it doesn't work. Ivermectin, which is kind of an antifungal, anti-parasitic drug, seemed sort of promising for a little while, but so they might actually be, I believe, working on an oral formulation of remdesivir, which is the one intravenous drug that is approved for people who are hospitalized. Um, so they're working on it. That would be definitely a huge kind of like what we have for the flu now, where we can, start people on oral medication quickly if they have flu-like symptoms. So
And is that something that you wouldn't need to be hospitalized for that in the same way, probably? I guess that's sort of up in the air at this point.
for oral medications,
If you were taking the oral medication.
yeah, I mean, the ideal thing would be that, someone could call up and they have COVID-like
Hmm.
symptoms, even if they haven't been tested, if the drug is safe enough,
Yeah.
we'd start them even before they get tested. So the idea would be to keep them from the hospital in a little bit the same way that the monoclonal antibodies
Hmm.
are being used for that. That obviously is logistically much more challenging because you want to get people tested, make sure they're positive, and then you have to set them up to get this infusion of monoclonal antibodies. So it's a little trickier it's not easy to do, but it does reduce the rate of hospitalization significantly. So if we could have an oral drug that did that, that would be fantastic. So I think everyone thinks that we're going to have to give boosters,
Hmm.
um, much like other shots. We don't really know how long. They're really doing it month by month. I mean, they came out just recently and said, okay, it looks like you really have great protection still at 6 months because that's all we know. It's only been
Hmm.
6 months. Some of the trials might have started July, August, but that's the longest data we have. Definitely the immune response from a vaccine is way better than the immune response from natural infection. It could be a yearly thing. It might only have to be every couple of years. The big question mark is going to be, um, are we going to have to do a little bit like we do with the flu and sort of stay ahead of these variants? Certainly the variants that are in New York right now, there's a New York variant and obviously the UK variant,
Hmm.
which I think people have heard of. Both of those are very prevalent, but the vaccines seem to work very well against those. So, um, you know, stay tuned. It's likely we're all going to have to get boosters at some point, but it may not be, may not have to be yearly. We'll see. A pretty good way to sort of check and see what people's antibody levels are, and they'll continue to do that. And if it looks like it's dropping off, after X period of time, then that's when they'll probably recommend it. It's pretty, my guess is it'll almost certainly just be one shot. Even if it's the RNA vaccine, it'll only be one shot instead of two.
Mm-hmm.
And probably you'll be able to get a Moderna if you had a Pfizer. But they're also going to look at that as well.
That's interesting.
They're doing a lot of mix and match trials, not in the United States so much, but in other parts of the world, using two different types of a vaccine for the first and the second shot. So we'll have more information about that as time goes on as well.
I know that there's a question of patents and like if the US is allowing other countries to produce vaccine elements, and that India is a big question right now because there's a big outbreak. I'm just wondering what the potential effect is here, maybe, I guess, or what we can do.
It's awful.
Yeah.
It's probably a combination of things. They're one of the largest vaccine producers in the world, right? They have really, really excellent factories that make all kinds of medications and vaccines. There are, talk of variants that have arisen there. We're going to be hearing about variants forever. This virus mutates not that quickly. We talked about that in other talks, but it does mutate. Just because it's a variant doesn't mean it's a variant of concern. It doesn't mean it's any worse for you, and it doesn't mean that the vaccine won't work. So I think right now, with significant portions of the folks in the United States becoming vaccinated, that's what's going to protect us here. What we need to do, though, is help the rest of the world, because if everyone isn't safe, then none of us are safe. And there's still a lot of controversy. It certainly is within the power of the United States to lift temporarily patent restrictions so that other countries could use the underlying technology. Not surprisingly, the companies are against it. We'll see what happens. I think it ought to be done without question. It's insane not to do that. I think we are starting to ship some of our unused vaccine, which I wish we had done a lot sooner, but AstraZeneca, which we have millions of doses of that we're not using and probably won't use. So we need to do more, and then just nuts and bolts stuff like oxygen concentrators and other stuff that we need to help them with. It will peak and it will come down, but it's pretty awful right now. I mean, you think back to Jonas Salk when, in the 50s, when he was asked about the polio vaccine, and he said, someone asked him, "Are you going to patent it?" And he said, "Can you patent the sun? This is for everyone."
Yeah.
And sadly, that's not the attitude anymore. So we'll see. I think there's a lot of pressure, but I hope they'll do that.
Yeah.
And we don't know why people are having these symptoms, and we don't know why some people do and some people don't. It's a little bit the same with the vaccines. Why does a person the same age, same gender, etc., why are they wiped out for 3 days with fevers and chills, and the other person's like, my arm is a little sore, no problem. We don't know. We don't know. I mean, those are things that they're looking at. I don't think it has so much to do with the immune response. Clearly, it doesn't have, in terms of the long haul COVID, doesn't seem to have necessarily any relation to how bad your disease was. It may have to do, there could be genetic factors, there could be, other condition, we just really don't know why it hit some people and not others.
So if you're confused, you're in good company on that.
Exactly.
Everybody's trying to figure it out.
That's something that they are trying to figure out.
And this is just something I was thinking of as you were talking about it, is this idea of long haul COVID not necessarily being related to how sort of intense your experience of the initial infection was. I think a lot of people are thinking, I'm younger, even if the people who haven't been vaccinated, I'm younger, even if I get it, like, I'm not going to be that sick. I think that those long haul symptoms are a really good further incentive of why it would be a good idea to get vaccinated.
Yeah. And,
Because you could be not very sick at all and still have long haul symptoms.
Yeah. And you can get very sick even if you're,
Yeah, exactly.
again, fortunately, I don't want to be too alarmist. Fortunately, it is true. The younger you are, the less likely it's to be serious. But why get it if you can avoid it?
Yeah, exactly.